Welcome to this explainer. I'm so glad you're here. Today, we're taking on a challenge that, honestly, a lot of people find incredibly daunting. But you know what? We're going to make it really fascinating. We are taking the dense, dry text of vascular intervention coding manuals and translating them into clear, logical, and highly visual rules. If you've ever stared at a surgical report just trying to figure out exactly how to code a complex angioplasty, you know exactly how tricky it can be to navigate the CPT rulebook. Well, today, we're going to demystify all of that. By focusing on the exact source material, we'll build a framework that actually makes sense of the procedure itself, the universal rules, and the specific codes. Okay, let's dive right in.
So here's our roadmap for this explainer. First, we'll cover understanding balloon angioplasty. Then we'll hit the universal rules of coding, followed by bundled versus separate codes, and finally, we'll wrap up with the specific arterial and venous angioplasty codes.
All right, let's jump straight into Section 1, Understanding Balloon Angioplasty. To really get the coding, we need to know what's physically happening inside the vessel. Basically, balloon angioplasty involves taking a balloon catheter and inflating it right inside an artery or a vein. But it's not just about, making space. It's actually about what the balloon does to the vessel wall. It stretches the intima, that's the innermost layer of the blood vessel, and it intentionally leaves a ragged interior surface after it's deflated. Sounds a little rough, right? But this ragged surface is absolutely crucial because it triggers a healing response while successfully breaking up the plaque that was causing the blockage in the first place. Usually it's done to treat an occlusion caused by atherosclerosis. But hey, the exact same codes apply even if the physician is using the balloon to treat a tear, like a dissection that happened during a procedure.
Now, a quick bit of history. Originally, this procedure didn't even use a balloon. Dr. Dotter, the pioneer here, literally used a series of progressively larger catheters to simply force the artery open over time. Fast forward to today's modern method. Now the physician passes a specialized, deflated balloon catheter to the exact location of the stenosis. Once it's in the perfect spot, boom, they inflate it. This action physically pushes the plaque back against the artery or vein wall, instantly improving the blood flow. And here's a key detail for us as coders. This inflation might need to be repeated multiple times, sometimes using different size balloons, until the vessel is finally clear. Definitely keep that in mind because it heavily impacts our coding logic a little later on.
Okay, moving on to Section 2, Universal Rules of Coding.
We all know medical technology is always advancing, right? So you might see some pretty exciting terms in a surgical report, things like cutting balloon or cryoplasty, which uses extreme cold. Naturally, you might think these super advanced tools require special, higher-paying codes. Sadly, they don't. Whether the physician uses a state-of-the-art cutting balloon, a drug-coated balloon, cryoplasty, or literally just a standard conventional angioplasty balloon, it's all just coded as standard angioplasty. Do not let the fancy terminology distract you from assigning the standard codes.
Now, I want to read this quote directly from the source material because it is absolute gospel for us. Quote, regardless of the number of inflations, angioplasty is coded once per vessel. Let that sink in for a second. A physician might spend a full hour doing 5 separate inflations on 3 different stenoses, all located within one single blood vessel. But because it's all happening in that one single vessel, you only assign one angioplastic code set. The work is defined by the vessel treated, not by the number of times they press the inflation trigger.
But what happens when a blockage just straight up ignores anatomical boundaries? That brings us to what's called a bridging lesion. This is a contiguous stenosis, meaning one continuous blockage that extends from one named vessel right into another. A perfect example would be a plaque that starts up in the axillary artery and extends all the way down into the brachial artery. So how do we apply our rules here? Well, if the physician treats that entire bridging lesion with one single inflation that opens up both arteries simultaneously, it's counted as a single procedure. You assign just one code set. However, if they have to do separate inflations, like one specifically in the axillary and another specifically in the brachial, then you actually assign codes for each artery. So it really all comes down to how the lesion was physically treated.
All right, please pay very, very close attention here because this is perhaps the biggest trap in vascular coding. Ready? Do not code an angioplasty if a stent is placed in the same artery or vein. I'm actually going to say that again just to be sure. If a stent goes in, the angioplasty code is completely off the table for that vessel. Even if the physician treats 2 totally separate areas within that single vessel, like let's say they stent one lesion and then they balloon a completely different lesion further down the exact same artery, the angioplasty is still swallowed up by the stent code. Stenting trumps angioplasty in the same vessel every single time.
Let's shift gears to Section 3, Bundled versus Separate Codes.
The modern CPT codes for angioplasty without stenting are totally comprehensive. Back in the day, codes used to be very specific to anatomical location, but the current ones are universal and they bundle a ton of work together. When you assign an angioplastic code today, whether they went with an open or percutaneous approach, it automatically includes the angioplasty procedure itself, plus all the necessary imaging required to complete the procedure within that artery, along with the radiological supervision and interpretation. You just can't bill for these components separately anymore. They're baked right into the base code, the whole shebang.
But hey, it's not all bundled. And this is where a good coder can really capture the full scope of a physician's work. If the documentation actually supports it, you can separately report vascular catheterizations. You can also report ultrasound guidance for vascular access using code 76937, or intravascular ultrasound IVUS using codes 37252 or 37253. Diagnostic angiograms, mechanical thrombectomy, thrombolysis, and even extensive arterial repairs can absolutely all be coded in addition to the angioplasty. As always, the golden rule of coding applies here. If it's clearly documented and it's on this list, you have the green light to capture it.
All right, Section 4, Arterial Angioplasty Codes. Let's look at the numbers.
For arterial angioplasty, where no stent is placed, your core codes are 37246 and 37247. Code 37246 is your base code. You use this for single artery angioplasty, or it serves as the very first artery you code if multiple arteries are treated in one session. Now, notice that little plus symbol next to 37247? That tells us it's an add-on code. You use 37247 for each additional artery treated with angioplasty during that exact same surgical session. So one initial artery and an add-on for every unique artery after that. Pretty straightforward, right?
But wait, there is a very common structural trap when we deal with bilateral procedures, meaning treating arteries on both the left and right sides of the body. If you're assigning that add-on code 37247 bilaterally, you must report it in units. You do not assign modifier 50 to the add-on code. Add-on codes already imply additional work, so using a bilateral modifier will almost always cause your claim to kick back or process incorrectly. Use units instead. Trust me on this one.
Now, we definitely need to talk about exclusions. Codes 37246 and 37247 are incredibly useful, but they aren't universal for the entire body. You absolutely cannot use these codes for lower extremity arteries being treated for occlusive disease. You also can't use them for intracranial arteries in the brain, coronary arteries in the heart, pulmonary arteries in the lungs, or within dialysis circuits. If your physician is working in those specific areas, you have to look up completely different code ranges. And one more thing, you can't use these codes in the aorta or visceral arteries if they are done in conjunction with a fenestrated endovascular repair.
Let's look at a few final arterial restrictions. When performed in the same artery during the same session, do not report 37246 or 37247 alongside codes 37215 through 37218 or the 37254 to 37299 range. Also, just a quick note on a recent update. In 2023, CMS created a code C7532 specifically for ambulatory surgical center, or ASC practices. If you are a physician coder or an OPPS facility coder, ignore that C code entirely. It's not for you.
And finally, Section 5, Venous Angioplasty Codes.
The structure here should feel like total déjà vu. For venous angioplasty without stenting, your initial primary code is 37248. This is for the very first vein treated. For every unique vein treated after that in the same session, you use the add-on code 37249. And exactly like we discussed on the arterial side, if you're assigning this venous add-on code bilaterally, you report it in units. Do not assign modifier 50 to 37249. The logic translates perfectly from arteries to veins.
And just like the arteries, the veins have their own specific traps and exclusions. You cannot use 37248 or 37249 for any interventions occurring within a dialysis graft or fistula circuit. That entire circuit has its own dedicated code family, specifically 36902 through 36908. Also, do not use these venous codes for an intervention in the tibio-peroneal segment if you're also reporting code 0620T, which is for endovascular venous arterialization of those specific veins. Recognizing these exclusions is really what separates a good coder from a truly great one.
And that brings us to the end of our breakdown. We've gone from the physical reality of stretching an artery wall to the precise alphanumeric codes required to bill for it.
We've covered bridging lesions, bundled imaging, the absolute stenting exclusions, and the exact arterial and venous code families. So, my final question to you is this. How will you apply these universal golden rules to systematically untangle the complex procedure reports crossing your desk tomorrow? Armed with this framework, I hope you feel fully empowered to conquer your very next coding challenge. Thank you so much for joining me for this explainer, and happy coding.